Good evening. Thanks to the organizers for this opportunity. So Amit left us with a slide actually, which said that what we are going to have in future. And we all heard the panel discussion by KP, where we are deciding how to use certain drugs in which situation. I will discuss something about comprehensive genomic profiling and what is its role in breast cancer management in the present scenario with some data on some data which is available. So, are the slides visible? Are they moving?
Yes, sir, we can see.
Yeah, fine. So, this kind of a slide, I think we see in all cancers in the last 1 or 2 decades, when we see that this particular cancer is not one subtype, and then we have multiple groups. The same thing is true in breast cancer as well. But what is more meaningful is that whether these subtypes, for example, now we can say that the genomic classification of breast cancer, we can have pathway-based group like PIK3, AKT, mTOR pathway, the BRCA, the ER signaling, the cell cycle regulation with the cyclin D1, CDK4, and the growth factor receptor pathway. From the talk which we heard before, I think we all know that we have drugs in each of these groups, so it is meaningful. So knowing them actually would make a difference, and that is what I would be discussing, and how to do this which test we are supposed to do in some situations. So breast cancer, like most of the cancers, has got definitely a heterogeneous landscape, and this actually becomes more complex in metastatic disease, which is also true in other cancers. And in metastatic breast cancer, the ER positive group, specifically, if you see this the slide, we can see that that is the one which looks like there are many options, and that is why we are having different options of treatment which is coming in this group of patients. And just like Amit said in his talk, 5 years of disease control with a new drug in combination with letrozole, I think these things will definitely go more and more, and we will have more and more drugs which will be coming in this group, is what I feel. So this is the a scale of evidence, the ESMO scale actually, about it's just a scale to see what is the evidence for clinical decision making based on the genomic alterations. So this actually classifies the genomic alterations into tier 1, tier 2, tier 3, tier 4, and X actually. The X means that there is evidence to say that this particular drug will not work there, and tier 1 is the best evidence. So as expected, the best evidence lies in HER2 amplification, BRCA, PIK3CA, MSI, NTRK, and the rest of the things are slightly below. And in each group, actually, the SCAT actually gives a B, C kind of an evidence based on the quality of data. So this actually suggests that multi-gene sequencing could provide benefit to patients pending optimal drug access. And most of these are detected by the Foundation 1 test, which is available. Let us see the evidence for comprehensive genomic profiling and targeted therapy. So this is one drug which was discussed in the panel discussion by KP. So we know about alpelisib, and we know that it is it works in PIK3CA mutated patients. So this trial actually SOLAR 1. If you take the intent to treat, there was not statistically significant difference in outcome. But when you took the PIK3CA group, there was a significant difference. The curves are widely separated here. The PFS is improved. And this actually has given us an opportunity to treat patients who progress with CDK4/6 plus AI in the first line. And we are all doing PIK3CA in most of these patients, and a liquid biopsy actually detects this. So definitely one of the pathways which can help us to decide a particular drug which will help to improve the outcome of these patients. That is one. That is about the SOLAR 1 trial. We have all heard about the ESR1 mutations. So when you see this, the ESR1 mutation is basically one of the mechanisms of resistance to endocrine therapy. And the mutations actually increase with from the primary to the metastatic to pre-treated metastatic. So that is how the mechanism of resistance mutations evolve. And to detect that, definitely we need to do a genomic profiling, or at some point of time in some patients to see whether say certain drugs can be used. Whether this will translate into a treatment, this trial, which looked at dexamethasone as a standard of care versus fulvestrant, the ESR mutant patients clearly had a different outcome with fulvestrant. So this trial actually helped us to decide on using fulvestrant versus dexamethasone in a particular group of metastatic patients. And this again is in the group which is ER positive. So that again underscores the point that ER positive, HER2 negative group might be the ones where we will be using more and more genomic alteration based treatments. This is when we say that we go to the difficult part of the metastatic breast cancer, that is a triple negative breast cancer. The moment we say triple negative breast cancer, we usually start and end with chemotherapy. But that is not the case now. We have the data from the PARP inhibitors. Now we have the data from some other group of drugs, the AKT targeted therapies. So two different trials looking at the same pathway, the same comparator arm, and similar kind of patient profile. The LOTUS and the PACT trial, they included actually comprehensive genomic profiling on the tumor tissue to allow retrospective analysis by biomarker status. The LOTUS actually tested the P10 status by IHC as well. PFS was the primary endpoint. What are the results like? So both the LOTUS and the PACT trial, if you see in the entire population, if you see, there is slight difference. The hazard ratios are similar in showing some benefit of the drug as compared to paclitaxel alone. But when we go to the specific biomarker-based analysis, which is the PIK3CA, AKT1, P10 altered population, the PACT trial, the hazard ratios are widely different. The graphs are, this is very small number of patients, but this is how science progresses as we know. So this trial tells us, this phase 2 trial told us that we have to look at this group of patients, and a biomarker selected TNBC treatment, a larger trial is required actually, which is very, very promising in triple negative breast cancer. Similar outcome from the LOTUS trial. Again, when you take the pathway based treatment, there is a much different outcome for these patients. So both these trials put together gives us an opportunity to look at this group of patients and try to use a targeted therapy along with chemotherapy in these patients. So from the ER positive, HER2 negative group to the triple negative, now we go to the HER2 amplifications. When we talk about HER2 amplifications, when we do a comprehensive genomic profiling, we will get the HER2 amplification results. Does this correlate with IHC and FISH, which is the standard which we do? So there is a 98.1% concordance and 99.3% concordance in an independent set, which is pretty good actually. So when you do a comprehensive genomic profiling, just like when we talk about lung cancer, where we do a NGS at the first line, because now we have more and more mutations and target therapies available. Maybe in future, we will be doing similar kind of test in breast cancer patients in metastatic disease to choose what is the line of treatment we are going to give. Having said that, there are certain things which is more than the standard IHC and FISH. So this trial, an interesting trial actually, the Summit trial actually, looked at the HER2 mutant tumors, regardless of the histology. And it looked at the mutation specifically. Predominantly, there were SNVs and insertions, and the effect of giving niraparib in these patients. So in breast cancer patients, neratinib in these patients, the breast cancer patients, the response rate was 32% at week 8. So that is significant, similar. And these variations, the mutations actually occur in 7% of the patients who have HER2 amplified metastatic breast cancer and 3% of the patients who have HER2 negative breast cancers. These are undetectable by standard of care tests like the FISH or the IHC, which is important. So we can get some patients who may benefit with neratinib treatment by doing a mutation analysis. Is there? Okay. So when we take this to the next level, the MUTE-HER trial actually looked at neratinib plus fulvestrant. Can I get? I'm hearing something which which is disturbing actually.
You please mute others.
Okay, fine. So the MUTE trial, somebody should mute the background noise also. The MUTE trial actually looked at fulvestrant plus naratinib in active, heavily pretreated ER positive HER2 mutant metastatic breast cancer. This trial selected patients based on HER2 mutation and not the standard HER2 ISC or FISH. If you take this trial in full, this trial is a negative trial because the trial had a primary endpoint of clinical benefit ratio and it did not meet the predefined efficacy criteria. But definitely there is a activity which is shown in the trial, and that is how trials move or the drugs move from later lines to the previous lines. I think there is a parallel session.
Yeah, just technical team, you are requested to mute somebody.
If I am audible enough, I can continue.
Please mute that noise, no?
Fine. So we all know about BRCA testing. I also mentioned briefly in the about triple negative breast cancers. So BRCA testing, from our ovarian cancer experience, we know that germline BRCA is not the only thing, and somatic BRCA, then the HRD, all these are group of patients where we can give targeted therapy and PARP inhibitors. So the data in breast cancer in this group of patients is evolving, but definitely there is a role of an extended BRCA testing, and that is best done when we do a comprehensive genomic profiling. So PARP inhibitors nearly doubled the progression-free survival versus chemotherapy in BRCA altered patients. When I say BRCA altered, it could be a germline or a somatic or an HRD. And the best way to do again will be a genomic profiling of these patients, which will also give us other information. So that is another pathway which can be detected by using a comprehensive genomic profiling. What about other drugs which are not available to us or which we discuss mostly in our meetings? The FGFR inhibitors, they are under investigation in solid tumors and in breast cancer as well. So amplifications are the major source of FGFR alterations in breast cancer. These are trials, phase 1 and 2 phase 2 trials, which have looked at FGFR altered breast cancer patients and targeted therapy in them with reasonable response rates and reasonable progression-free survival, whether with fulvestrant, when an FGFR inhibitor is given, the progression-free survival almost doubled actually. So definitely something to look at, another pathway to be explored. Then the usual mutations which we see when we do a comprehensive genomic profiling, we may get a TP53, an RB1 or NF1 mutations. Mostly, we don't have any targeted therapy based on that, but they have prognostic significance. If you see the overall survival of TP53 altered metastatic hormone positive HER2 negative breast cancer, it is hugely different. The patients do worse if you have a TP53 alteration.
So you are just left with 2 minutes to conclude your presentation.
Sure, I don't need 2 minutes actually. So we will just discuss about liquid biopsy. Liquid biopsy in breast cancer can be done in other solid tumors as well. When we do liquid biopsy, it is sometimes when we don't have a solid biopsy to be done, or when we have to monitor a response. And liquid biopsy has come big way in breast cancer. The PIK3CA mutations we are doing by liquid biopsy, and we have data of liquid biopsy in all types of breast cancer. So this is a trial which actually aims to use the liquid biopsy to match breast cancer patients to different targeted agents. So the ESR1, the HER2 mutation, the AKT1, in all these pathways have a targeted therapy to be tested. So, and some of the early data actually suggests that a liquid biopsy based treatment actually makes a difference. So I think that is what I have in the study. I have given you 1 minute back actually. Thank you.